University, and actually I'm an associate professor of urology. I'm working in Ankara University School of Medicine, a consultant urologist, and my main area of expertise is urology. I'm only dealing with the stone surgery and prostate enucleation, laser enucleation, for now almost more than 10 years, and my main practice actually focuses on the lithotripsy and the stone disease. So in today's presentation, I will try to talk about the lithotripsy devices that we use in urology. And first of all, as being a scientist and also on the other side of the table as a customer, let me just see someone presenting with a device from the representative. We actually want them to have, first of all, enough knowledge about the device that they distribute. And also, they really should believe in the product that they try to sell. So we just understand as a physician what's the knowledge, the level of knowledge of the distributor or the partner. And it's also important for our choices during our practice. So regarding lithotripsy devices, we actually have two different strategies. One is the intracorporeal lithotripsy that we use during the surgery, and the other one is the extracorporeal lithotripsy, that the shockwave device we use to disintegrate the stones. So for really with the stones, actually we have mainly two strategies. What we need to do is we need to fragment the stone into finer pieces and take them out of the body. So to do that, we have mainly two strategies. One is fragmentation and the other one is dusting. Fragmentation means we break the stone into very fine pieces and take them out one by one. And for dusting, we dust the stone to very fine particles, less than actually 200 micron, and they are evaporated spontaneously from the body. We should decide on what technique we use, depending on the type of the stone, type of the patient, the anatomy of the kidney, everything. But in the end, we need to have enough knowledge about what our device is capable of and how we should use it. Other than that, there's no use of these lithotripsy devices. So for stones, what we have as options is, first of all, we have the shockwave lithotripsy that's still on the market. It's a very effective technology to disintegrate the stones without any operation. And other than that, we also have the operations, and depending on the size of the stone and what we have inside, we mainly have two options. One is the ureteroscopy, the keyhole surgery that we go through the urethra, and do every ureter and the kidney and do everything from the natural orifice. And the other one is the PCNL, that we drill a hole from the skin, get into the collecting system of the kidney, and fragment the stone and take them out of the body. So in order to establish a good surgery, you need to have an efficient lithotripter to establish the stone. So this is our EAU guidelines. This has not changed now almost 10 years, and we have the treatment options of PCNL, flexible uroscopy, and shockwave lithotripsy. And for stones that are actually less than 2 centimeters in diameter, shockwave lithotripsy has still a good place. It's still the primary treatment option. And also for stones bigger than 2 centimeters, it can be considered as a secondary procedure. However, shockwave lithotripsy is now in the market for more than 40 years. And it has really good treatment outcomes. It's really non-invasive. You don't need an anesthesia for this procedure. You don't need an hospitalization. The complication rates are low, the success rates are high, and the cost is also low for our reimbursement systems, but still, it has a decreased role in our daily practice. And this is another study coming from North America, about 10 years of follow-up for the main practice in North America, and we can see that the rate of use of the shockwave lithotripsy has decreased by 33%, and for ureteroscopy, there is a 40% increase, and for PCNL, it's mainly stable, from 4% to 5%. The reason is PCNL is for the bigger stones, so you don't have any other option than PCNL for those very big stones, but URS and shockwave can be used interchangeably, and in the recent years, the shockwave is actually losing a lot of blood, and we are practicing more and more with flexible ureteroscopy. And this is a more global perspective from different countries, including Brazil, Canada, Australia, New Zealand, UK, and USA. and a longer follow-up in about 25 years. And again, we can see that the rate of use of the shockwave lithotripsy is decreasing in almost everywhere. And in this study, the total share of shockwave among the total treatments decreased by 14.5% in about 25 years, and in the recent years, this drop is more dramatic. However, this question, is shockwave lithotripsy dying? The definite answer is no, because it still has a good role. It's a very cost-effective treatment, but certainly we use it less and less in recent years. And these are some of the topics from our international congresses, and you can see some very provocative titles like "The era of shockwave lithotripsy is over," or "The final decade of the shockwave lithotripsy by retrograde interventional surgery." These are the debate speeches in these international congresses, so it's definitely having a less role in our daily practice. So the question is why? Why do we apply shockwave lithotripsy less and less in our daily practice? First of all, one of the main reasons is the results of the shockwave lithotripsy vary a lot between the operators. It depends on the device you use, technique you use, and patient selection, of course. Also, we have very good technical advancements in the urology. We have now high-power lasers, very efficient laser devices, the fancy endoscopes that have very beautiful images, and also the patients now require more and more technology to get rid of the stone as soon as possible. But also, another important thing is the insurance policies and the reimbursement. This is really very important because we are, as urologists, paid more for a surgical procedure than a shockwave lithotripsy. So in the end, it's more profitable for the hospital and for the doctor, so that we also select our treatment strategies depending on the reimbursement as well. And of course, the patient expectations are important. With shockwave lithotripsy, we disintegrate the stone in the body, and the stone needs to be expelled by the patient. So they do not want it. When you do a PCNL, you take the fragments out of the body, and the patient is still free immediately after the operation. And so patients also expect better outcomes after the procedure. So, first of all, the first point was the outcomes of the shockwave lithotripsy vary between centers and operators a lot, and it's a problem. So we need to improve the outcomes of the shockwave lithotripsy. So how can we do it? First of all, the proper patient selection is very important. I mean, if you think that this patient is going to be stone-free, about 80% chance after the procedure, then you can do a shockwave lithotripsy. But if the chance is like less than 20%, there's no need to try a shockwave so that you will have a disappointed patient. And the other one is you need to have a dedicated team to apply any surgical procedure. I mean, we do PCNL with a team. We need to have a good technician, a good nurse, or an assistant to help us. But for the shockwave, it's also the same. If you just let your technician do the job and do not follow the patient during the procedure by yourself, then the outcomes will not be good. So you should also operate through some good technical details. So proper education of the physician that's going to apply the shockwave procedure is also important. And also proper patient informing is important. You need to have good informed patients that they have really realistic expectations after the procedure. So it's not a major plan in the end. So it's an application of a medical procedure, and the patients should know what they should face after the operation. So proper patient selection is important, and we need to, as physicians, we need to be well informed about the indications and the contraindications of shockwave lithotripsy. And while selecting our patients, we need to take into account a lot of factors like the stone size or the 3D volume of the stone, the location, the skin to stone distance that has really good, has very important effect on the application of the shockwave lithotripsy. Also, there are other parameters like the enhancement in the CT texture analysis. These are all now that we just calculate and study for the shockwave lithotripsy procedure. And this is actually one of the studies that we applied some factors, that we evaluate some factors that can have an effect on the outcomes of the shockwave lithotripsy. And in the end, we find that the stone diameter, stone skin distance, and the density of the stones are really important, and we actually have some cutoff values for these parameters. And if we have a favorable patient, then this shockwave lithotripsy outcome, the stone free risk can be as high as 95% when we apply it correctly. And As I mentioned before, we need to have a dedicated team for shockwave lithotripsy. I mean, when you distribute a shockwave lithotripsy device to a hospital, but they will not do what they are going to face, and if they don't have a dedicated team, a good place for the shockwave lithotripsy, then the outcomes will definitely not be good. In the end, we need to operate by the book. There are a lot of technical details to apply shockwave lithotripsy, so proper education of the physician and the team is very, very important. I mean, when you ask a doctor, do you let your nurse or technician do a retrograde internal surgery to the patient? The answer is definitely no. But for shockwave, in most of the hospitals, still the technicians or the nurses are applying the device. So the outcomes will not be good when you do not take care of the patient by yourself. And as I mentioned, the reimbursement and insurance is very important for our selection of the procedure for our individual patient. For instance, in our social security system, for shockwave, we are allowed to do just 3 sessions in 6 months of duration for each side of the kidney. So, and regarding the reimbursement, for shockwave lithotripsy, the amount we are paid is maybe 1 in 50 of a PCNL and 1 in 20 of a ureteroscopy. So we are paid less. That's why now physicians are selecting the urology procedures instead of shockwave lithotripsy, despite the patient will have favorable outcomes. And this should actually be corrected. I mean, the reimbursement by the insurance is mainly based on the name of the procedure, but it should be based on the success of the procedure. I mean, if you treat your patient successfully, I mean, whatever you use, the reimbursement should be the same. And if this is the case, most of the actually urologists will select shockwave lithotripsy over ureteroscopy or PCNL in most of the cases. And the value of the reimbursement should actually, for the stone surgery, should be adjusted to the clearance of the stone without any complications and without need for an auxiliary procedure. So if you are doing 2 or 3 sessions of auxiliary uroscopy, then in the end, it's not a successful procedure. So this is actually a study from the United States that I like a lot. In this study, what they did was they gave a hypothetical case to the stone patients, an 8mm asymptomatic stone, and asked about their opinions about the active surveillance. That means that we just follow the patient, we do not make an operation, or shockwave, or retrograde internal surgery. And they give the success rates of 65% for the shockwave and 90% for the RIRS. And in the end, ask the patients, what would you select for yourself? And about 45% of the patients actually prefer shockwave lithotripsy because of the good success rate and non-invasiveness. But more importantly, 85% of the patients just say that we rely on what the physician actually tells us. So our opinion as the physician is more important than that, because especially in Turkey, in our country, the patients usually say, okay, doc, you can do whatever you like. Which is the most successful for it in your hands, just do it. So it's really important that we need to have everything in our hands and select according to the patient characteristics. And to get a better patient perception of the procedure, we need to educate our patients well. And these are 2 studies again from a group that we developed a decision aid for our patients to select between retrograde internal surgery versus shockwave lithotripsy for a 2 cm stone in the renal pelvis. And when you inform the patient well, there's a significant improvement in the level of knowledge by the patient, and they have a significantly decreased decisional conflict to select any procedure. And in the end, in this study also, we asked the patient, what would you prefer? 2/3 of the patients actually prefer shockwave lithotripsy over retrograde internal surgery when you inform them well in an objective manner. So we need to actually take good care of the technical details. It's really important in order to have a successful procedure. We should also train our team. So the shockwave delivery rate is important, power ramping is important, pain control during the procedure is important. I mean, if your patient is just moving when you apply shockwave lithotripsy, then of course you're not going to focus the stone and it will be an unsuccessful procedure. And also, well-designed and precise localization system for the stones is also important. And Also, the focal zones and the shockwave energy values should be adjusted based on the procedure. So, this is a study again coming from the United States and Canada. And in this study, they just grouped the physicians into two groups. The blue ones are the endourologist specialists, they are fellowship trained. And the red ones are general urologists, they do not have any fellowship program during their education. And when they are compared for selecting between shockwave or flexible ureteroscopy, the endourology trained ones select flexible ureteroscopy and endourology procedures more, and the ones that are not endourology fellowship trained, they select shockwave tutorsy more. So the more we get trained, the more we like to operate. So just to finalize with the shockwave, actually, this gentleman, Christian Shossi, he wanted the shockwave tutorsy more than 40 years ago. And just think that it comes with a time machine today and tells us that you're holding surgery, but in the end, I have a new technology that you can treat the stones as an outpatient procedure. There is no anesthesia for those patients. There is no body fluid-related transmission of some infections. There is no need to have expensive devices and disposables. You don't need any postoperative care. You do not hospitalize the patients. The stone failure rates are high and complication rates are low. And in the end, most of us will just tell him, okay, I want this technology. But in the end, now it's over 40 years old. It's losing a lot of blood. It's not so popular. But in the end, it definitely has a good role in our daily practice still, especially in the developing countries. So patient selection is the key for a stone patient. I mean, depending on a lot of factors, we need to personalize our treatment options. So we need to take into account the patient-related factors, social factors, stone-related factors, and the pelvic issue anatomy, of course. What I mean by social factors and the patient-related factors, I mean, think about a 25 years old soldier or a pilot that has really a hard job to do with a stone and has no comorbid conditions, and he needs to get rid of the stone as soon as possible. The application of our procedures will be different from a 70-year-old lady with coronary artery problems, anticoagulant medication. That's totally going to be different. Also, the stone-related factors are important, and that's, as I mentioned, the 3D volume of the stone, the hardness of the stone, the value conditions of these should all be taken into account. And again, when we go back to our guidelines, we have the endourology procedures for all of the stones, and as the endourologist, actually, the real fun for me starts in here, and I operate the patient in my operating theater. So we no longer do any open surgery for stone cases. We mainly do endoluminal endourology through the natural orifices or with the percutaneous approach, and very rarely, if you need a reconstruction of also the urinary system, we apply laparoscopy or robot-assisted surgery for the stones as well. So for this one, we need the intracorporeal lithotripters for our procedures. We need to disintegrate the stones inside the body. So we have the ballistic pneumatic lithotripter, the ultrasonic one, and also the lasers. I'm not going to get into the details of the lasers. It's beyond the scope of today's presentation, because in each laser, actually, I can give a 1 hour talk with the technical differences and everything, but I will mainly focus on pneumatic and the ultrasonic lithotripters. So, efficient lithotripsy is the key for an ideal surgical procedure. For the stone surgery, we need to be successful, that is the real stone-free status. We need to be safe without any complications, and we need to be fast, both during the operation and after the operation. I mean, we need to be fast during the surgery, in a short operation time, and we need to discharge the patient as soon as possible. And in order to establish these goals, we need an ideal surgical technique. And to do it, we need an efficient lithotripter. In the end, if you cannot disintegrate the stone in the body, then you will not be successful. So, this is one of the procedures that we mainly apply for the huge stones, that is the percutaneous nephrolithotomy. What we do is, we just access the kidney's connecting system with some imaging, that is either a fluoroscopy or an ultrasound. And after that, we create a tract from skin through the collecting system. We see the stone with our endoscope. Then we fragment the stone with a certain energy and take the pieces out through the sheet or the working channel. So in order to do a good surgery, we definitely need an efficient lithotripter, and also we apply different surgical techniques during these procedures. We usually combine PCNL with the flexible uroscopy. This is myself doing the flexible uroscopy part, and my resident is doing the PCNL. This is a combined surgery. This is the image from the nephroscope, from the percutaneous access, and this is the image from the flexible scope. So we just reach all parts of the collecting system and take the stone pieces out by fragmentation. This is another case. We have these all white ones are the stones. We have a lot of stones inside the collecting system. This is the view from the nephroscope. Again, the flexible scope is taking out the fragments from the kidney's upper pole. And this is a huge one that we cannot take in one piece. So we apply ballistic pneumatic lithotripsy. We just apply the force on the stone, it breaks, and the pieces are taken out. In the end, in order to establish the complete stone clearance, we need to have efficient lithotripsy. You see, these are really hard stones. Also in Turkey, we have a lot of big and hard stones in the stone belt, especially the southern part of the country. The patients come from the southern part, also for the Arabic countries. They are really huge and very hard stones. So in the end, in order to be successful, we definitely need to be fast in the operation, especially with the fragmentation. So we need to determine for which case, which device, which lithotripsy to be efficient. In the end, we also have enough knowledge about the technical details of the lithotripter. I mean, with the lasers, also we have different types of probes and different types of lasers. Some of them are good for dusting and some of them are good for fragmentation. But it's also true for the other intracorporeal lithotripters. So we need to have enough knowledge about the available sizes of the probes and the technique that we can apply. And these should actually be compatible with the endoscope of the surgeon. I mean, as urologists, we need to have enough technical knowledge about the endoscopes, their outer diameters, their working channels. In the end, some of the nephroscopes, they have limited working channels. So if you try to put a huge lithotripsy probe inside that, then it will not fit. Or you can fit, but you will have no longer any irrigation. So in the end, we need to be careful about the selection. I mean, you can just distribute a lithotripter with a huge probe, an ultrasonic one, but in the end, if it's not compatible with the working channel of the nephroscope that the surgeon uses, then it will not be a successful procedure in the end. So for the standard PCNL, we can either apply ultrasonic or ballistic lithotripsy if the working channel of the nephroscope is wide enough. Usually, in most of the countries now, 26 Chevalier diameter nephroscopes are available, and they have the working channels up to 12.5 French. And in the end, you can apply your lithotripsy between 9.9 at least a probe, and by this way you can have efficient ultrasonic and ballistic lithotripsy. But if there is a mini PCNL procedure, it means that the sheet that they apply to the skin of the kidney is limited to less than 20 French in diameter, and the nephroscopes we use are usually 12 French, and therefore the working channel is limited to 5 French. And in the end, if you try to put a 4.5 French ultrasonic probe, you can apply it. I used to use it sometimes, but in the end, the irrigation is really limited. Instead, what I would prefer is a 4 French ballistic probe. So I know the technical details of my instrument, so select my lithotripter based on what the device lets me to use. So this is the Lithobox 0. This is the mini PCNL procedure. We are applying the surgery from a 16 French sheet, and the nephroscope is just 12 French, and the working channel is just 5 French. And this is the ultrasonic lithotripsy probe that we apply to disintegrate the stone. During ultrasonic lithotripsy, our main idea is, of course, to suck the pieces out through the channel of the ultrasonic probe. But with such a fine probe, it's not possible to suck all of the fragments. So the main strategy is to fragment with ultrasonic and then take those fragments out. So we need to adapt our strategy. You see, this is not a very huge stone, but it's also a hard one. It's disintegrated well with the lithotripter, but the suction is limited. In order to have an efficient suction with ultrasonic lithotripter, you need to have at least 9.9 or 9.8 French of diameter for your probe. However, with the standard PCNL, in this case, we have a very huge stone inside the kidney in different parts. This is like a 5 centimeter maximum diameter, and with the 3D volume, it's really very huge. So we now working through a 24 French sheet, and the nephroscope that I use is 19.5 RD diameter, and it lets me to use up to 12 French of working instruments. So by this way, I'm using a 9.9 French ultrasonic probe here, and very efficient lithotripsy is possible. But also, a good device should be operated well. This is very important. And usually when I have some guests in my department to show the procedures, or when I visit them in order to give some technical operation details, in the end, these lithotripsies are not the magic words. I mean, you need to apply them appropriately. If you just stick the probe at the very center of the stone and push the pedal, it doesn't disintegrate, it doesn't do anything. In the end, you need to know how to apply it. Usually, what I advise is the peripheral parts of the stone are more softer and more breakable, so that when you apply in the peripheral part of the stone, then you will have good fragmentation and at the same time good aspiration. And also, you need to have a good technician or nurse that knows how to assemble these devices. These are actually very simple. After a simple education, you can do it. And also, sometimes the probes are used a lot of times, then it means that the efficiency will not be good. If you have some problem, first of all, just try to replace the probe, and then it can become much more effective. So in the end, as I said, you need to know how to operate it. And also you need to have good irrigation, which also needs suction. I do my stone surgeries in supine position mainly, so that the patient is just lying down and the water is also coming out of the sheet very spontaneously and very fast. So that a good irrigation is very important, it's mandatory for these cases. And in the end, in such a huge stone burden, it just took less than half an hour to disinfect the entire stone and take all of the pieces out. And these are the stone dust that we had after the surgery, and we also washed out a lot of fragments from the system. It's a very efficient lithotripsy. And this is the ballistic part of the Lithobox Zero. It's also very efficient. We have the 4 French probes for the ballistics, so it's very efficient for the mini PCNL as well. But if we are doing a maxi PCNL, then it's much more efficient. This is a very hard stone. The Huntsville unit is more than 1,300 Huntsville units. But with the low power holmium laser, it's also available in the OR here, but it's not so efficient. So I just shift to Lithobox Zero, and with the ballistic lithotripsy, it's very fast. About 4 years ago, we published a study about the comparison and combination of the low power holmiums with the ballistic lithotripters, and you can just use them in combination during mini PCNL. It's very efficient. And recently, we also compared for the mini PCNL, the high power holmium lasers with the ballistic lithotripsy, and in the end, they are both efficient. But if you do not have a high power holmium, then having a ballistic lithotripter in the OR really helps a lot to fasten the procedure. This is a bladder stone, multiple stones inside the bladder. So just to show both ultrasonic and ballistic, this is the ultrasonic one. You see it also fragments. You don't need to suck out all of them. You just fragment. At the same time, while doing fragmentation, it sucks out the dust. But in the end, you can also fragment with your ultrasonic and take those pieces out. So before we continue with the ballistic and take those pieces out, these are bladder stones, and we do not operate through the urethra. Instead, we put a suprapubic tube inside into the bladder from the skin and apply the lithotripsy from there in order to limit the trauma to the urethra. So in the end, as I mentioned, we need to know what the device is capable of, and by this way, it will be much more efficient surgery. And this is the last case I would like to show to combine low power whole linear lasers with the ballistic ones. We have a huge stone occupying the half of the maybe the kidney. So we just start with a mini PCNL in this case and get into the connecting system with a 12 French nephroskop. And these are the jack stones inside the lower pole of the kidney. So we fragment them with the whole linear laser and take out the fragments piece by piece. These are smaller stones, so I can treat them with the whole linear laser. But now I have a huge stone inside the renal pelvis coming into the lower pole. It's really very hard stone. And the lithotripsy with the whole linear laser is not good. So what I do is, I just insert my bigger sheet, the 24 French, and put the 19.5 French nephroscope with a huge working channel. And by this way now I have the capability of fragmenting it much more efficiently. This is the ballistic lithotripter. And so we just fragment the stone into pieces of 5 or 6 millimeter in diameter and take those out one by one from the percutaneous sheet. I have stones in another calyx, so I need a second tract. Here I make a second puncture that is also mini 16 French, and just fragment the stone into the pelvis and take those big pieces out of my first access. And by this way, the combination of the laser, whole linear laser with the ballistic, we are much more efficient. And the total duration of the surgery was just less than 40 minutes, and the patient is smoke-free, and we can discharge the patient the next morning. In conclusion, in the end, what I can say is personalized stone approach is important. I mean, we need to personalize our treatment options depending on the patient-related factors, stone-related factors, and also what we have in the operating theater. If you have a good lithotripter like this, but no shockwave machine, then you can go to PCNL. If you have a good laser, and also the patient has some comorbid conditions using anticoagulant medication, then you can go with flexible uroscopy. But in the end, shockwave lithotripsy has definitely a good role for the routine daily practice. We should just decide on based on a lot of factors and make some calculations for our patients. But in the end, if you are operating or if you are applying shockwave lithotripsy, the success of the procedure, the stone-free rate, actually relies on an efficient lithotripter. So if possible, we need to have everything in the OR, and we need to know for which case, which method, and which device, so that we will be successful and will serve with the excellent outcomes for our patients. And I'd like to thank you all for your attention. If there are any questions.
Hello, very nice presentation, Doctor. I'm Ali from Brazil, and I have been working with ballistic and ultrasound systems more than 20 years with a Swiss company, and trying to find other suppliers for these devices. So first of all, just a comment about the shockwave in Brazil. I see very clear that it's going down. Not the reason that you show us there, but more on the economic aspect. It's a high investment, you need a room extra for this, and I see Brazil really decreasing the extracorporeal shockwave procedure. I believe it's better than the other one, but anyway. This is just a comment, but I have 3 questions. Do you use by only ultrasound? You use only the probe with ultrasound, or do you use it combined in mainly of your procedure? Or how do you, let's say, how do you make your decision on using only ultrasound or combined or ballistic?
First of all, I do not use the combined with this device. The reason is it's not compatible with my nephroskop. In the end, in order to have, when you put the ballistic probe inside the ultrasonic one, then you block the working channel, and it's actually not good for the idea of suction of the fragments during ultrasonic lithotripsy. So if I have like uric acid stone that has a hospital yield of about 700, it's a huge one, and I have good access that I just use the ultrasonic one. But if I usually have a hard stone, then I apply the ballistic mainly. I do not use the combined a lot because at that time I need a huge ultrasonic probe, and the working channel of my nephroskop is limited to 12 French of instruments. And when I apply the 12 French of ultrasonic inside the ballistic, then I have no irrigation. That's because of my setup in the OR. But if you have a 6 French nephroscope with a huge working channel, it's up to 14 French, then you could, of course, use it, the combined lithotripsy. But I either use ultrasonic or ballistic, not in combination.
Okay. And using this, the litho box zero on ultrasound, is it effective?
Yes, it's quite effective.
And the ultrasound probe, it is reusable?
Yes.
And do you use how many times generally you use it?
My average is about 8, but it depends on the type of the stone and the duration of the procedure. Right? If you are just operating for a 2 centimeter ring of double stone with ultrasonic, then you do not need to suck all of the fragments. You just stick your probe in the middle of the stone, and you have like 5 pieces of 4 millimeter stones, and take them out without a spray. So if you just do those cases, you can use up to 20 times. But there's a huge stone, 6 by 5 by 5, and you apply ultrasonic lithotripsy. For such cases, you can apply just for 4 to 5 cases, I believe. But in the end, in average, I can say 8 to 10.
Okay, thank you. And just to ask questions, mini PCNL in Brazil is quite more popular, let's say, on the uros. You said you use only more the ballistic system for the mini PCNL. Why don't you use the ultrasound for mini PCNL?
Yeah. The reason is again depending on the instrument. I mean, with the mini PCNL, my nephroskop, ultra diameter is 12 French, and the working channel is up to 5 French. So the smallest ultrasonic probe is 4.5. And when I put it inside the working channel, I really have very limited irrigation inside the system. And also the inner diameter of this 4.5 French probe is really very limited to suck out the fragments. And in the end, as I cannot suck those dust with the ultrasonic probe, the tiny one, I just fragment instead. I just use the ballistic one because the ballistic probe is 4 French in diameter. So it's better compatible with my working channel. So in the end, I just fragment without sucking. I fragment and take the pieces out, and you actually put it in effect in the mini PCNL. And it's actually a wonderful procedure. Now, more than 90% of my cases are with mini PCNL, even for the stagger stones. We just apply the standard one, more than 24 French, just in less than 10% of our cases. That's why I still believe that ballistic lithotripsy is very efficient, very cheap, and very sturdy. I mean, you don't have a lot of mechanical problems with the ballistic lithotripsy. That's why I use it.
Okay, thank you.
Any other comments or questions?
Thank you. That was a very good presentation. That's very impressive. Mr. Marlow, from London, I'm a urologist. I do DCLs. I've just completed 1.0. I had some problems with the suction, with the ultrasound probe actually. So we're using it quite a few times, and I think about 4 or 5 times is about the maximum of the stool by being really PCNL. I agree with you when you do a mini PCNL, that the ballistic one is better for a mini PCNL. But what we find when you use just the ballistic one with the small fragments, and the fragments get shoot off in various cases, and then you have a flexible cystoscope, the standard PCNL and a flexible ureteroscope. With the mini PCNL, then get the fragments out. So I tend not to use the ballistic as much as you do. Maybe I should change, but I find the fragments go all over the place. How do you stop them? So it doesn't happen to you as well, then you have to chase them.
Okay, so do you operate a probe position?
Yeah, supine.
In?
Supine.
Supine. Yeah, actually, I'm doing supine PCR, only supine PCR for now more than 10 years. And almost all of my surgeries are combined surgery with retrograde access as well, unless the ureter is not wide enough. So, what I do is, of course, there's a risk of, especially in dilated systems, the stroke fragments can go anywhere. But it's not a problem of only lithotripsy, it's also the case with the home iliac laser as well. And also during ultrasonic lithotripsy, it can still happen because you fragment and you suck out the fragments, but in the end, some of the fragments can go anywhere inside the collecting system. And what I do is at the end of the procedure, I check the entire collecting system with a flexible ureteroscope. And if there's any residual fragments, I just take them out with the basket. The pass-the-ball technique I apply very regularly. And I actually published 2 different studies just to evaluate the role of the retrograde axis. And we find that if we do a retrograde ureteroscope at the end of the procedure, we just can reach all of the collisional system in about 95% of the cases. And we just improve our stone rates from 70% to more than 90% with the application of this. But if you are right, it's always a problem. And depending on your comment on the number of uses of ultrasonic probes, as I mentioned, it's actually a function of these, the type of the stone and the volume of the stone, of course. If you just apply it for smaller stones, then you can use up to more than 10 times. But in the end, if you're dealing with a huge stone, then of course it's limited to a very limited number of cases there.
Thank you.
Any other